Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, a community pediatrician and your host for today. I'm very excited to welcome today's guest, Dr. Nelson Rosen from the Pediatric Surgery Division here at Cincinnati Children's. Today's discussion is a consult on pilonidal cysts and pilonidal disease. So first of all, welcome, Dr. Rosen. Thanks for joining us today.
Thank you very much.
First, let's let our audience get to know you a little bit. Can you tell us a little bit about your background, where you're from, a little bit about your training, maybe some other interests you have?
Sure. So I'm from Philadelphia originally, and that's where I discovered surgery. I went to Temple University School of Medicine and trained in surgery on Long Island, where I met my mentor, a surgeon named Alberto Pena, who was a pediatric colorectal surgeon, and it was working with him that I discovered this little niche area that became my really lifelong interest. And we worked together there. I went away to University of Montreal for my pediatric surgery fellowship, and then I came back to work in New York with Dr. Pena and the group there. After a few years, he actually picked up with and left New York and came to Cincinnati to create the Pediatric Colorectal Center here with one of my partners. I stayed in New York, and about 15 years later, things had changed. Dr. Pena had moved on to Denver, and there was an opening here at the center. And so then I got a call from one of my partners, who's the director of the Colorectal Center, Dr. Jason Frischer, who said, would you come on out to Cincinnati? And I've been here for 7 years, and I love it here. It's a great place, and we have a really unique center here where we can focus really in depth on pediatric colorectal conditions, one of which is pilonidal. So we include that here in the Colorectal Center. But, I live here. We've got 2 kids. They're all in college now. My wife, Jeannie's a pediatric radiologist. We're just thrilled to be in the Cincinnati area.
Great. Well, welcome to the podcast today. First of all, let's start with talking about pilonidal disease. In my practice, it's something that I see a few times a year. A kid will come in with, some discomfort with sitting, pain in their lower back, pain at their upper buttocks. Can you talk a little bit about what is pilonidal disease and how does it happen?
Sure. Pilonidal disease is like a real nuisance diagnosis that affects healthy people in their adolescent years and young adult years. It does not occur before adolescence, actually.
Is that because of, hormonal levels, oil glands, things like that?
We think.
Okay.
Like nobody's really made that link. There's actually one of my colleagues is a pediatric surgeon at Stanford who does a lot of neuroblastoma research, and they deal with like estrogen receptors in that world. And they've done some studies looking at some of these tissues, certainly to see if there's like hormonally responsive things, and they've found some things. So that's interesting, but like you just do not see it in the children before puberty.
Okay.
Which is sort of one of the areas where people can get confused. Sometimes there's like a baby born with a sacral dimple, and like that'll get sent for an ultrasound, and some radiologists will actually use the word pilonidal in the report. And that confuses parents. Next thing you know, we get a 2-month-old baby in the clinic for evaluation of a pilonidal, and we're like, hold on a second here.
Yeah.
Sacral dimple, totally different thing. Let's not be confused.
So if we're seeing a prepubescent kid, not pilonidal disease, something else.
Something else.
Okay,
now, like there's always no nevers, like there are in the spectrum of things that we see. Sometimes we'll see like a 10-year-old. And like the 10-year-old, they don't really, like, they're not advanced on the Tanner scale, but they're starting, and like this is one of the ways in which they manifest.
Okay.
So like, and I see that because we see over 200 pilonidal patients a year. So it takes numbers to pick up somebody that is on the very early spectrum of it. Most people are in the middle to, late adolescence when they start to have the issue.
Okay. All right. So what is pilonidal disease?
So pilonidal, I like to think of it as like a complicated pimple in the butt crack.
Okay.
Not elegant,
Sure.
we tend to speak in plain English because, we're trying to explain this to people, and we use the term natal cleft a lot, but patients don't so much know from natal cleft. But so if you explain it like that, like for some reason, and now that's the hardest part of it, because I can't tell you what that reason is. People have theories about it. Like one of the big pioneers in pilonidal disease was a surgeon in Eugene, Oregon named John Bascom. And John believed that you develop a little infection around the hair follicle, like in the hair follicle, around the hair shaft, and then the hair would fall out. And now you'd have like a large pore, and he called this a pit. And in pilonidal patients, if you look closely directly in the midline, you can see visible pores that are bigger than all the pores around them. Mm-hmm. We call those pits, and that was like the John Bascom term. And he really did a lot of great work in pilonidal, so many of us learned from him and follow his techniques. But just imagine that somehow hairs get worked into that little tiny hole. This is one of the common things people believe, that maybe they're ingrown hairs, and they're not ingrown hairs. That's a totally different thing. And I think the pediatricians probably see a lot of folliculitis and all sorts of things from clipping and shaving. But this is not that. They're not ingrown hairs. They're hairs from the outside that manage to work their way into that tiny little opening and then get stuck under the skin. And then it becomes bigger. It becomes like a little bit more of a pimple. And then it can take on a variety of forms. I see several reproducible phenotypes. The most common type that I'll see is that becomes like an abscess cavity that on its own burrows out from a different location. Like it drains, it makes a drainage hole elsewhere, usually at the top of the cleft, on the left or on the right, sometimes in the middle, sometimes the bottom of the cleft, but it can be any of those places, and they get this big hole with granulation tissue heaped up around it, like a big bump there, and the body just did that. That's one of the ways that we'll see it present. But sometimes it presents that they just have this horrible acute abscess. And some people's bodies don't don't make that drainage hole. And then they come in and they're like jumping around and they can't sit and they're in pain and they're miserable and they need an acute drainage. And then there's the people that they don't really, they drain outside too efficiently, and their body not just makes a little hole, but breaks down into an open wound in the cleft.
Okay.
These are the people that that the process for some reason doesn't hurt them. They come in and they're like, yeah, I had this for like a thing, and I've had some, it's been bleeding. It's been bleeding. They call it bleeding. It's just sort of like reddish drainage, but I've had bleeding for a year and a half. Okay, nobody's bleeding for a year and a half. But they've had drainage, and then by the time somebody looks down there, they've got like a 3-inch beefy red wound in their cleft. You say, that doesn't cause you any pain? Like, yeah, no, not at all. And the only way that a person could develop such a thing on their body is if it didn't cause them pain. Right? If it caused you acute pain, that's when people seek care. It's the things that tend not to cause you that much pain that they don't seek care. And that's another part of the problem with pilonidal. This is hitting teenagers. They're really sensitive about their bodies. They don't want to talk to their parents about their butt crack. They don't want their parents looking at their butt crack. And that by the time it rises to the level of where a parent identifies that their child needs to be evaluated, it's often fairly advanced in the process, with the exception of those patients that do not drain at all. Like they come in and they're really in horrible pain. They cannot sit, and they get acute care.
So for those people with the chronic drainage, is infection part of that? I mean, because the ones that I see are more the acute cysts that are clearly infected. But these ones that are just chronically draining that serosanguinous, red fluid, is there bacterial presence there? I mean, more than just flora, or is this more of a inflammatory condition?
No, there certainly is bacteria more than just like regular flora. And this is where it becomes complicated. When you have a patient like that, and when you get the true story, they've had small flares over time. Like,
Okay.
it got bad like in March, and then then it kind of drained on its own, and then I left it alone and didn't tell anybody about it, and then in August it started hurting again, so those are acute flares on chronic, and certainly bacteria is all over this thing. And we don't do a lot of studies where let's just keep swabbing and quantitate the bacteria. We're not doing that. But when you look at it from the other direction, when you try to get it to heal, sometimes no matter what you do, you get it down to a chronic little wound. If you don't start adding antibacterial things, it will not get to the finish line.
Okay.
So we start with sort of a variety of antibacterial wound adjuvants along the way.
Okay. And we'll get into those kind of treatments down the road. But as far as typical bacteria we see, whether it's more the chronic infections or the acute flares, is there a typical lineup of bacteria that you see when you culture these things?
It's really mixed.
Okay.
You can see gram positives, there's gram negatives, and there's anaerobes always, which is one of the reasons we tend not to culture a lot. Like when I do drain the abscess, I do a culture, but I do a culture for a subset of patients, for the non-responder, right?
Okay.
Like, if I drain them and they get better, then it doesn't, the only interest in the culture is from an epidemiological standpoint. But like as a provider, as a patient, like it's irrelevant.
It doesn't guide your treatment.
Right, you got better.
Yeah.
Better is better. I can't improve on better. But like, let's say I had somebody who was a true non-responder. Like I drained them. There's a component of cellulitis. Like I have them on antibiotics. 3 days later, like, doc, I'm dying. Like it's getting worse. Well, then I'd look at this culture and see if it grew something that they said was resistant to what I have them on, and there's an opportunity to tweak.
Yeah.
If they grow something that it says it's sensitive to what you're on, well, then it didn't help you anyway. But
Sure.
I still culture when I drain.
Okay, so these are typically going to be teenagers with this kind of off and on, waxing and waning type symptoms. What else might they say? Like what other history aspects are we going to hear from the patients or from their families?
Yeah, I hear pain or soreness down there. The drainage is very common. Some people will call it drainage. A lot of people will call it bleeding. Mm-hmm. And then I have to differentiate, because people will come to us with hemorrhoids, uncommon in the pediatric age range, but not zero. So is this the bleeding? Is this somebody with a hemorrhoid? Is this somebody that's bleeding because they have a fissure? Somebody that's bleeding because they developed a perianal abscess and have a fistula, and that's why they're bleeding because it's going down the IBD path? Or is this the bloody drainage, bloody-ish drainage of a pilonidal? They're going to have a very different look on exam. So that's where you can help distinguish that. And then there are a subset of patients who just come in with complaining of an odor. There's something wrong down there, and it's just there's an off smell to it.
Okay.
And that's one of the things that we'll hear as well.
Okay. And other than puberty, are there any other risk factors that put you at higher risk of developing pilonidal disease?
Not really.
Okay.
That's the startling thing, and in many ways the frustrating thing. It's that, when you learn about this, I learned about it. It wasn't one of those hot topics in medical school. We did that 3 weeks session on pilonidal. No, it might have been 3 seconds. And then in residency, it wasn't big, in part because surgeons did back then. Most surgeons were doing big wide excisions. And then they'd make these gigantic cavernous wounds, and people were miserable, and they didn't all heal, and the patients were miserable, and surgeons had a bad tool. And so when you don't have a good tool, you don't like dealing with it, the patients don't like it, and you become very frustrated. So people didn't really talk about it a lot. But having now over the years acquired a variety of much better tools and more evolved therapies, I've had a chance to really take care of over several thousand pilonidal patients, and in our population it's 50-50 men and women. Okay. Very different than the adult population. The adult population, it's about 75% men, and we don't think that's because it's a different frequency. We think adult women just aren't coming in with this, aren't really talking about it or complaining about it, and it's going still undiagnosed. But in our patient population, it's 50-50. And we have hairy people, and we have people that practically have no hair on their body. We have thin people and very heavy people, people that are sweaty, people that are bone dry, people that are very hygienically challenged, and people who are super clean and meticulous. And it cuts across all of these categories, which is really, it's the great equalizer.
Yeah, sure. Family history, do these tend to run in families? My dad used to deal with this, now I'm dealing with it kind of thing?
Most of our patients don't have a family history, but some do.
Okay.
I'd say most of these are sporadic.
Sure.
Every now and then you're like, oh, yeah, like my sister had one, my father had one. Like, okay. Yeah.
Okay. So if I get this kid coming to my office, I'm, take my history, do my exam, it looks consistent with, whether an acute developing infected cyst or more the chronic draining type cyst. As a general pediatrician, what would you say my first steps should be?
So once you get the story, and one of the things that I always ask in the history is inflammatory bowel disease.
Okay.
I don't tend to go into a lot of GI symptoms unless they start with it, or if I see something that has me thinking in the direction of IBD. But I always ask about it. We tend to see a subset of patients that have both pilonidal and Crohn's, and it's useful to know that.
Okay, so these are presenting together. This is not Crohn's masking or mimicking pilonidal. These are kind of separate but potentially related processes.
Correct.
Okay.
So we have a subset of patients like that. So personally, and being a colorectal person, I always ask, one of my history questions is there any history of inflammatory bowel disease or anything like that in the family? I do ask about other pilonidals. Probably the two most important comorbidities to know about for management are inflammatory bowel disease, because then there's the whole medical implications of that, and diabetes.
Okay.
So like any diabetic that has something that puts them at risk for infectious processes, like if I'm trying to manage a pilonidal patient with diabetes, I need to know all about that.
Sure.
And then just the exam. So like when you come to the Pilonidal Center here, we tend to do a very focused exam. So we get everybody laying face down on the table, and I find everybody's like kind of up on their elbows, and I say, just relax. Let's get you down off your elbows, kind of like hugging the table a little bit. When people are up on their elbows, they're tensing up their buttocks. They're pretty tense anyway. We're trying to put them at ease and relax them so that we can get a decent look at the crack.
Yeah.
They're all sensitive teenagers. 99% of them, 1% is like, hey, doc, take a look, but that's not common. So we want to make sure that we check with them. Is it okay, if your parent stays here or you want your parent behind the curtain? All our exam rooms kind of have a curtain just in case somebody opens the door so they could be there. If they really want the parent out of the room, we're never a single provider alone with an adolescent. We always make sure we have the nurse there, and we're a team when we do this. And we take a real good look at that crack. We want to look all the way up and down and really spread the cheeks and look in there. Because for the first thing I'm going to observe is how hirsute the patient is.
Okay.
The next thing, and I'm going to look, what do I find in there? And I'm looking for all the things we've sort of touched on briefly. I'm looking for pits in the midline. Pits, by the way, those visible pores where you're looking, you're like, oh, normal pore. Oh, that's a pit. And the way I described that to a family, I said, you ever look in the mirror and look closely at your face, at your skin, and you're like, oh, your cheek looks a certain way, but when you look at your nose, you can see pores. And and that's what I'm talking about. When you look in the natal cleft, you'll see skin. Oh, there's like a clearly a large pore there. That's a pilonidal pit. And every now and then you'll see that pilonidal pit, and there will be a hair sticking up out of it. So then what you do with that is you take a tweezers. You have to have a tweezers. We have these disposable suture removal kits. They got a tweezers and a scissors. And I feel bad wasting all the scissors, but you take out I give them to the family. So I take out the tweezers and I slide that hair right out. And I show the parents, because this is something that they could do. If you could slide those hairs out before they get worked in, then you're potentially that's one ER visit you may be avoiding.
Yeah.
So I look for pits, and I look for any of these drainage holes, and then this is one of the challenges in the pilonidal world, the nomenclature, because it's not all agreed on. One person's pit is another person's sinus. We use these terms, but they're not clear definitions. So when we see in the direct midline a visible pore that's like maybe no more than a millimeter or two, that's a pit. All right. Pits don't occur off the midline. You just don't see up the butt cheek, though, there's a pit there. No, there's no pit there. If you see something off the midline, it's never going to be that tiny, and it's going to be a big, fat, round opening. That's a drainage hole that an abscess bored itself out through.
Okay.
And then the other thing that you'll see in the midline is holes that are now bigger than a pit. So when the hole looks big enough for you to say, I think that's a hole, like when you're 3 millimeters and up, we can see 5 millimeter or 10 millimeter holes right in the midline, these big holes that look like they've got skin lipped and going into the depth. We call those sinuses. Mm-hmm. And then you'll see other things are wounds, where there's actually in order to call something a wound, you probably have to be bigger than about 7 or 8 millimeters. You need to be able to see a beefy raw surface. And if you just look and I see a round circle of opening that I see darkness through, then we would call that a sinus. But once that opening is 1 centimeter, 1.5 centimeters or more, then you look in, you're like, oh, I see raw, beefy surface. Mm-hmm. That's a wound. And so I look for all of these things. And one of the things that helps me see this is I have a clipper there in the office. I used to have Bic razors. There was a guy named John Armstrong in the Army, did a study and had a captive audience, all the soldiers, and they had pilonidals, and they'd come into his clinic, and he would just shave them once a week. And he found that if you just shaved people once a week, over time, their pilonidals would resolve. Not 100%, but it was really hey, you don't need to do big wax on all these people. You can just get rid of the hair. And that's sort of how it started to become known that getting rid of the hair was really one of the cornerstones of good pilonidal management. So when I started taking care of pilonidals back in the early 2000s in New York, I had all these disposable Bic razors. That's what they had in the operating room for skin prep, for shaving an area before we would do surgery on somebody that had hair. And they were terrible. And we used to I'd go through 3 razors per person before I would finally get down the hair. Thankfully, these days we have these clippers. And in the surgical world, this was a big deal because somebody figured out that if you shave or clip, you have a higher rate of wound infection after surgery if you shave. So the clippers became a quality measure, and all of a sudden all these operating rooms had these clippers with disposable clipper heads. You get a fresh clipper head for every patient. So it's always sharp. It always works well. And they're wet dry. You can wash the thing in the sink. And they sit in a rechargeable base. So
you're going to the barber?
Yeah, it was beautiful. They had these beautiful clippers. So the next thing you know, one of our operating room clippers got relocated to my office.
Okay.
And ever since, we've bought these clippers. And so when we have a pilonidal office, unlike any other surgical office here at the medical center, we routinely clip our patients. And we think that that's really critical. We say from this day forward, that natal cleft area has lost its hair privileges. It's just not working out. So you know what? You want to make this better? Just get rid of the hair. And we'll take that one step further. We'll say, and we think you should make it permanent with laser hair removal.
Okay.
And it makes a difference. So we're on the exam, though, as I digress extensively. The exam to us is critical that we get all the hair out of there, and then you can really see things. Oh, I see the pits, I see this, I see that, which is really hard to see in a forest of hairs, So we clip them and we get it all clean. We also take pictures. Mm-hmm. It's all, secure, put in the electronic record. That's really important to us. But by tracking it photographically, we can say, oh, it looked like this then, it looked like this now. And there's some patients that we follow for a very long time, and we can get a sense of where they are in their overall treatment plan. And then I will look down by the anal canal. And this is one of those challenging areas because there are sometimes I will get sent a patient for fistula in ano, and they're concerned that this might be Crohn's and they have a perianal fistula. And I'll look at it and I'll figure out that it's pilonidal. And sometimes, like rarely, I'll get somebody sent where they think it might be pilonidal, and I say, I think this is really more fistula in ano, and I'll take it that different direction. It's really hard, like because there are people whose pilonidal drainage opening will be so low, like their pits and their active process is in the center of the cleft. But you don't see them when they were swollen. You just see them now that their body drained out through an opening and it's sort of chill in the cleft. Mm-hmm. But that drainage opening tracked down instead of up. And I don't know why they do that. Like, it's the randomness of an abscess. But sometimes that abscess will be really down by the anus. So I've had over the years a whole bunch of patients that have been referred for perianal disease that ended up being pilonidal disease. Sometimes I tell that if I really can't tell in the office, because I'm not going to do an anoscopy in the office and start like putting probes through things, but I'll do it under anesthesia. If we take them to the operating room and we'll take a good look, and then all things become clear.
Okay. So you get your good exam.
Yeah.
And in our office, where we don't have all the tools, but we got some, what would you say our next step should be?
So I think that next step can vary a little bit, but I would say the best next step for the overwhelming majority of your patients is referral to a pilonidal person.
Okay.
For
long-term management.
For long-term management. And not everybody that comes to our office. So, again, truth in advertising, most pilonidal people are surgeons. So like, when you're a hammer, the world looks like a nail. But we don't operate on everybody. And sometimes we meet people and say, like, if I were you, I wouldn't have an operation. I would go get laser, and I would do X, Y, and Z, and we reinforce the conversation about make hygiene like a special part of your routine, we do have some people who are hygiene challenged and they really need that support. We do recommend the hand shower. We recommend clipping it. If you can't clip it, use depilatory. Sometimes I'll have a person who's like just graduated high school. Now they're in like the dorms in college. They don't live anywhere near a parent, and they don't have a trusted ally to clip them once a week, check the pits, and get the pits out of there. So we tell them about Nair or some other depilatory product, and we give them instructions on that. So if you're looking at somebody that looks like it's really mild disease and their symptoms are mild and it hasn't really been going on a long time, you can certainly and should institute all these non-operative measures. And that's not a person that really must go to a surgeon. If you're just you can do all those same things, and anybody can counsel, keep it clean.
Yeah.
You have a bowel movement, maybe that's a great idea to get in the shower and clean it after, or maybe get a washlet or a bidet attachment for your toilet to enhance your ability to keep that area clean. Keep the hair out of there. You don't need a surgeon to tell you that. So, but then if you think that, well, this keeps happening, it's been going on for a while, like, I've followed it for a while and it seems to be getting worse, or if their symptoms at the outset seem to be pretty severe, or like maybe they are on the cusp of like they're under their parents' care for the next 6 months and they're going away to college, and I want to get them sort of in the best place before they leave the house and go half a country away, then refer to a surgeon. And specifically, this is where you have to have some savvy about what resources exist in your region, because every surgeon will accept the patient. Every surgeon will see a patient with pilonidal, but many surgeons are still following very archaic management methods and are not up on the latest and greatest of doing minimally invasive pilonidal treatments, of which there are a variety. Here we do what's called the Gips procedure, named after Dr. Moshe Gips, who's a surgeon in Israel. And he basically took a concept from the 60s. These two British surgeons, Lord and Millar, came up with the idea of like, you don't need to do a big, giant cut, like the shark bite, as I refer to the traditional excision. You don't need to do that. You can just kind of clean out the holes with brushes, get all the hair out of there, and just clean it up and clean up the edges of the wound so that they'll heal. That stayed popular in a small group of surgeons in Commonwealth nations. But like in the States, yeah, we're not that. And that never got popular here. And then flash ahead 40 years, and then Moshe Gips sort of comes back on the scene with take these little punches and punch out the holes, then work through the holes and clean out the inside. And that's it, you're done. That was pretty revolutionary. So a bunch of us picked up on that. I did mention John Bascom. John Bascom pioneered what's called the cleft lift, which is also called a modified Karidakis flap. And that is a wide excision, but it's a wide excision with off midline closure. And that is a technique for patients. It used to be the only thing that I offered back in the early 2000s before I knew about the Gips procedure. But that is an operation that works extremely well. It's a big deal for patients, so I was only really offering it after non-operative measures weren't working for 3, 6, 9 months or whatever. I'd follow for a period, and if people were really suffering, I would offer the cleft lift. It's a great operation. It's still an ambulatory procedure, but it's about 2.5 hours of anesthesia. You do need narcotic pain medicine. People have a drain sucking out fluid for about 5 days while they're at home. It has a over 90% success rate, though, and they leave closed up. They don't have a big open wound. So that's a great option for people. But the Gips procedure really revolutionized the management, and all of a sudden now we're offering these little minimally invasive procedures to a lot more people. And I think that's fine because, it's a 20-minute little trip. We do it under sedation. There are people who do it in an office setting. I personally think you can get a better clean out with a sedated patient, but that's just an opinion. But the point is that you have to know who in your area is doing advanced techniques and is up on the literature. And when you talk about laser, they have resources and they can direct you in the right way, and they really know how to offer a modern, evolved, and evidence-based service. I still get people that had pilonidal surgery at other places where they did things which I say, really? In 2025, really? People doing these big excisions and midline closures, they break down and they have a high failure rate. So we don't put people through things that we know are going to fail,
And here in Cincinnati, do we have a pilonidal center?
We actually do. When I came here, I've been here 7 years now, and I found that, like a lot of centers, great docs doing their best to take care of patients, but the approach was not really systematic. And so I in Cincinnati fashion, put together a working group and said, all right, who wants to participate? Which surgeons are most interested? And then let's cohort clinics and let's get nursing expertise and make sure that we have consistent nursing. So this was a project that we ran through the colorectal center. Okay. And so we have the colorectal nurses, but a subset of them who specialize in pilonidal. And we started out with 4 surgeons, but it's really 2 of us, myself and Dr. Rebecca Brown, see all the pilonidal patients. And we have regular clinics every week that are dedicated just to pilonidal patients. We also have 2 nurse practitioners who see patients as well. So any day of the week, we can see a pilonidal patient with an acute issue.
Okay. So seeing that this is often a chronic issue, referral to the pilonidal center or a specialist like that sounds like a good idea. What about, that kid, he's on our schedule, on, my schedule, say something like bump. And you walk in, you got the teenager, he's not sitting, he's leaning over the table, and, within a couple minutes, you're kind of zeroing in on an acutely infected pilonidal cyst. In a general pediatrics office, do you recommend incision and drainage right there just to relieve the pain and the pressure? Is this something we shouldn't mess with? Kind of what are your thoughts on, acute drainage of that, that big old, obviously abscess that's staring you in the face?
Right. So draining the laudable pus there is one of the oldest things that we've done, and I think that, it's, again, variable by comfort. If you have the comfort in doing that and the resources to do it in your office, then absolutely,
Yep.
You can certainly do it, and I'm sure you'll do a great job, because it's not terribly complicated, and as you say, it can be the most rewarding thing. Like, they feel better almost instantly, and they're leaving your office in a much better state than when they got there. Now, just a couple things to be wary of with that. First of all, let's say you're not comfortable and it's really not your thing. Then don't stress about it. Like, if you're in our area, just call us up, and we're going to say, like, during the day, we'll make that happen in the office. After hours, we have an emergency room for that, and I'll have staffing from the surgical, team that's on, and they can handle any abscess. And the truth is, like, also any ER can handle that abscess. Mm-hmm. So if you don't have that resource, then by all means, don't stress about it. The one thing to be cautious of is, let's say you're like, I'm comfortable draining it, but I'm on the fence. Like in my exam, I'm struggling it's certainly painful and bulging in one area, but it doesn't feel fluctuant to me. Like, I don't feel like this squishy, and I'm comfortable poking into the area with the squishy. Well, okay, so you got two options there. Like, I would say those options are, put them on antibiotics and bring them back in a day or two, or maybe try to needle aspirate. Because whenever I've been in that situation, I've numbed up and then I take an 18 gauge needle. It's got to be an 18 gauge needle. If it's like a 21 gauge needle, you're not going to get pus through that thing. It's got to be that pink hubbed 18 gauge needle. And I just aspirate in that area. I always find pus where I thought I was going to find pus, if I'm doing that. And then if it's like, oh, this is like really, it's a bit bigger than I thought, then I can just make a small incision right over it, right where I put the needle. And if you absolutely aspirate and you really don't get anything, then you validated that they need to be on antibiotics, and you haven't made an incision, and you just have like a tiny little needle stick. So no harm in that. Mm-hmm. So I would say, if you're on the fence about, like, I'm not sure how much liquid I'm going to get, then just do an aspiration. And if you aspirate it fully, then you don't need to do an incision, like you just saved the patient 4 more millimeters of wound that they need to heal. I certainly think that if you're set up for that and comfortable with that, mm-hmm. do it.
And then you follow that up with antibiotics, sitz baths, warm compresses.
Yeah.
Do those help?
I tend to follow it up with, I put them all on antibiotics.
Okay.
My patients, like, by the time they're getting to us, they're pretty bad. So I put pretty much everybody on Cipro and Flagyl unless there are allergies. I certainly think that, like, as a first line, Augmentin is a reasonable thing. Clindamycin's a reasonable thing. Like, there's Bactrim is a pretty good antibiotic. Those are reasonable things, and combinations, with the metronidazole if you think you need the anaerobic coverage. I don't tend to put people on topical antibiotics for acute abscess. We do topical antibiotics when we're struggling with wound healing and trying to decolonize wounds. The other adjuncts, once you've been drained, I don't really focus on compresses and baths. I find most people aren't bath people, and if you ask them to do baths, it's a huge time ask, and they're just not going to do it.
Okay.
So, like, it might make you feel better that you asked them to do it, but they're not going to do it. So I tell people just to shower. If you want a bath, like, again, there are bath people. Take the bath. The bath is awesome. Okay, soak in warm water. That's great. I do ask if people have a hand shower. The kind of shower you can take off the wall and can direct at the area. If it's an acute abscess, don't make it aggressive, but, like, certainly wash well in that area. But I think drainage and just antibiotics and time is really the bulk of that. But also, if you could get the hair out of there, and if there's hair sticking out openings, try to extract whatever you can get.
Okay.
And then we do fairly close follow-up. We'll want to see them back in, like, a week or two to see how things are doing. And then, like, are we teeing up for a minimally invasive procedure here, or did we just get you over an acute issue? Sometimes they're acute abscess in that subset of patients that comes in with horrible pain. The reason they're in horrible pain is that their body doesn't drain well, so you sometimes can look down and see no pits or holes, and that's in part due to the swelling. Once that infection clears, 3-4 weeks later, you can go back and look and you're like, oh, I can see 3 pits there. And that can give you the diagnosis. So we'll see everybody back and do a good re-exam.
Okay. And other than like a complicated abscess that we don't feel comfortable draining, are there any other times this takes on more of an emergent, like send them to the ER immediately type thing? Do we see spreading infections, bone involvement, osteomyelitis, anything like that?
Yeah, we just don't see those things.
Okay, good.
The osteo, that is an interesting question, because if you look at our whole discipline of pilonidal, there are people with non-healing wounds and people that struggle and high recurrence rates. And so nobody's done systematic studies of biopsying and doing a culture of the sacral fascia and the bone there to really see, is there an incidence of osteo that we're just not clearing, and that's why a subset recur. I can tell you, we had one patient in the past year that we did diagnose with a sacral osteo and that we did targeted therapy for that. That's like 1 in 1,000. But again, in part, that's one of those areas that we don't know enough yet, but we tend not to go after it, and most people will get better. So, if we're not looking and not finding, you can take that a variety of ways. But again, most people do get better without targeting that. Yeah.
Okay. So it sounds like for management, drainage if necessary, clean the area, get the hair out, antibiotics, referral to a pilonidal center. That's kind of the mainstays. Is that about right?
That's really it.
Okay.
There's no mystery there, and I think personally, no role for imaging.
Good.
Every now and then, we were talking a second ago about that patient where I'm not sure if they need to be drained or not. And this is where a lot of emergency rooms have developed a practice pattern of getting an ultrasound to look for deeper pus. If I'm going to get an ultrasound, I'm going to stick a needle in there and aspirate it, and then I'm going to find that pus. I don't need that ultrasound to tell me that it's down there, or I'll just put them on antibiotics, let it mature a little bit more, and then it'll become very clear. I don't think there's a benefit to that ultrasound. And then there are people that have sent these patients for sacral MRIs. And we don't get a lot of sacral MRIs for this, but when we do, they see these inflammatory changes. Sometimes radiologists are savvy enough to know that they're looking at a pilonidal, but again, pilonidal is one of those least imaged things, so the radiologists don't tend to see a lot of pilonidals by imaging, so they sometimes are trying to figure out what they're looking at there, and sometimes they can use confusing words that pop up on a report that now parents get almost as quickly as we get, sometimes even quicker. And so I would say try to avoid getting imaging in these patients and avoid the confusion that creates. If you think that you might need imaging, that would be an indication to send to a specialist.
Perfect.
I think the key is to just be up on the latest and greatest on this. Understand that the basis is all those non-operative things we talked about is really the foundational aspects of the care. And then you want to take it to that next level. You just got to be up on the latest and greatest and offer your patients really modern, evolved, evidence-based techniques.
Well, Dr. Rosen, thank you so much for joining us today. I've certainly learned a lot. Our patients are going to benefit from this. For our listeners, just a reminder, today's episode is available for CME credit. You can find the link for that in the show notes, and I hope everybody has a good rest of your day.
Thank you.